Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. Today, we're discussing how to treat comorbid chronic pain, orthopedic conditions, and neurologic conditions with Dr. Laverene Garner. Dr. Gardner is a board-certified neurologic clinical specialist and currently works as an assistant professor in the Department of Physical Therapy at Winston-Salem State University. Prior to her role as professor, Dr. Gardner developed the vestibular therapy, mindfulness, and integrated health components of a concussion recovery clinic at Camp Lajune, where she treated individuals with chronic neurologic conditions. Today, Dr. Gardner teaches doctor of physical therapy students how to provide evidence-based care for those with pain, as well as orthopedic and neurologic conditions. On today's episode, we discuss how Dr. Gardner's passion for integrative healthcare shaped her early career and research interests, why exercise intensity matters in neurologic conditions, how to prescribe physical activity for individuals with neurologic problems, and what special interest or consideration should be made, how to promote neuroplasticity in Parkinson's disease and multiple sclerosis through diet and nutrition, how lifestyle-based interventions can improve the function and health of our nervous system, and finally, how to empower people to take control of their health and their long-term recovery. Dr. Gardner did write the chapter on neurology in the Integrative and Lifestyle Medicine in Physical Therapy textbook. So if you're following along with that textbook and you'd like to learn keys to a healthy nervous system, make sure to check out chapter 15. Of course, you can buy that text on Amazon or at optp.com. Okay, without further ado, let's begin and let's meet Dr. Laverene Garner. Hi there, Laverene. Welcome to this week's episode. It's great to have you here.
Thanks, Joe.
I'm excited to speak with you about this intersection, this dual diagnosis of caring for and treating, evaluating the person who has both orthopedic and neurologic problems. I think it speaks so well to what we do here on this podcast, and of course, what we do as pain professionals. Oftentimes, you even hear people say it's neuromusculoskeletal pain or it's a neuromusculoskeletal condition. So I know as a physical therapist and a neurologic certified specialist, this is your bread and butter. But tell me a little bit about yourself and how your kind of personal and professional experience as a PT has kind of brought you to where you are here today.
Yeah, so I've been a PT for 20 years now, and currently I work as an assistant professor at Winston-Salem State University in their PT department. And interestingly, I started out with high aspirations of wanting to be a manual therapist. And so I took a lot of manual therapy courses early in my career, but never made it to be certified or anything. Anyhow, I spent the majority of my first 7 years as a PT working in largely orthopedic clinics, but occasionally for short bursts of time, I worked with neuro population. And then I moved to Jacksonville, North Carolina, where Camp Lajune is, and ended up being the only person in town really that worked with people with vestibular problems. And so I ended up, because I had this neuro experience combined with orthopedic experience, treating a lot of people post-concussion. And that really kind of led me to really appreciate the intersectionality of the way the brain impacts pain and vice versa.
So tell us about Camp Lajune a little bit, since you kind of breezed over that, but I'm curious about your experience there and what the camp attendees were like.
Yeah, so Camp Lajune is a Marine Corps base. And so I ended up actually going to work on base after working in the civilian sector there for a long time, and helped start and develop an interdisciplinary concussion recovery program, particularly the vestibular and then the yoga and meditation components of the program as well. And so with concussion, especially people that have had a lot of concussions, they tend to have a lot of chronic pain complaints as well. And in the military population, they're carrying a lot of gear. And so they often have a lot of low back pain complaints that are chronic in nature. So with trauma histories. So it's a very complex population. And I had the opportunity there to co-treat and develop mindfulness and cognitive behavioral therapy programs that combines yoga with mental health professionals and also chaplains. So it was really an integrative and actual, I think, highly integrative place to provide care and to learn and grow as a clinician. And it really gave me a profound understanding of the complexity of the human existence.
So when we hear things like TBI, people may or may not be familiar. Obviously, there are higher rates of vestibular problems in the TBI population, but chronic pain is something new. We often don't think that, oh, if you have a TBI, it's a risk factor or the prevalence is higher for developing chronic pain. Can you make some of the connections for us? Obviously, on this podcast, we obviously hear that, pain is a nervous system / brain problem, but what is it about the TBI experience or the TBI injury that I guess leads to that central sensitization that all of us are so familiar with?
Well, I think one of the first things that happens is a TBI is a trauma. And so the brain stores it as a trauma sometimes. And the people that I see, I have a skewed lens when it comes to concussion because everyone that I see has chronic symptoms. Most people recover fine, right? But the people that I have worked with did not. So first of all, there's a trauma. And I think when you hear leading experts, I'm not a leading expert on chronic pain management, but when you hear them talk about it, they talk about the event, if it's stored as a trauma, can contribute to chronic pain. So that I think is the first thing. The second problem that's frequently associated with chronic pain is just the autonomic dysregulation. And that's really common post-concussion, is that the ability to downregulate the nervous system doesn't always just return to normal. And so sometimes there has to be specific attention paid to that. And then the head is attached to the neck. So when you have a concussion, you often have cervical problems as well. And then the oculomotor system, which is, I think for an orthopedic therapist, maybe they're least familiar with the oculomotor system. But when someone's oculomotor system is not working well, it can lead to eye strain and tension headaches, in addition to the cervical problems. So it's really important that all of these things are treated well and that the person's symptoms are not minimized and that the person's validated at the onset of injury if they're having symptoms. Otherwise, this cadre of issues, this kind of mixing together, leads to real problems for people that are difficult to treat if they're not managed appropriately up front.
I love the way you brought all those pieces together. I can hear a piece of polyvagal theory that even sits in there.
Yes.
Because you're talking about obviously trauma and the autonomic nervous system and chronic pain. And there have been a couple of papers that actually applied polyvagal theory to the development or the persistence of chronic pain. I mean, all of this experience that you had really sounds like it was key to shape kind of this integrative biopsychosocial approach that you now have as a professional.
Yes, it really was. And I frequently say that I owe a tremendous amount to the people, to the military and individuals that I got to treat, the service members, because they taught me so much that I feel like I didn't necessarily deserve or to learn, but through their lived experiences, they gave me huge gifts as a therapist that I'm responsible now to pay forwards.
So the yoga came in to your practice and obviously to this approach at Camp Lajune, because it sounds like you were trying to target, part of that was targeting that autonomic regulation or dysregulation that people were experiencing. Was that key in their rehab program?
Yes. And then I think when you start to, so one of my favorite approaches to yoga overall is understanding the koshas. And so lots of the people that I worked with at Camp Lajune also were experiencing an inability to connect meaningfully with family members and life again. So they'd had this kind of spiritual wound or injury that had happened. And so yoga was a way for them to kind of relax for a little while and learn to move again without experiencing pain and understand that they have some control of their life. And then the mental the behavioral health therapist, the psychologist or social worker that would be there with me would be often doing additional coaching about specific things that people could do to connect from a joy perspective in their lives as well. So it was really a holistic way to work with people.
And was the mindfulness component part of the yoga, or was it a separate class or session?
Yes. So my meditation training has been primarily with I-Rest Yoga Nidra. I don't know if you're familiar with that or not.
Please tell us what that is.
Sure. So I-Rest Yoga Nidra was developed by Richard Miller, who is a clinical psychologist, and Yoga Nidra is a play on words. So it's waking up to the fact that we've been asleep. And so in I-Rest, I is a little I, and so it's putting the ego to sleep and becoming aware of things that are controlling our lives and such, so that we can choose the most auspicious way to move forward. And so this is the kind of meditation that I most frequently taught. And I can say the military service members really loved it because they could rest and find a place of peace to be in for just a little while.
So as you're talking, obviously you're sitting in your office at the university.
Yes.
You teach in a DPT program. Have you been able to, I'm going to veer just for a moment off of the topic of ortho and neuro problems in our patients. Have you been able to implement some of that mindfulness into the curriculum with your students?
Yes. So interestingly, right now, I am coaching them through or advising them through their comp exam that they have to pass to get through our curriculum. And one of the things that I talk to them about now is how to self-regulate so that they can make the best choice possible on the test, right? So this is low stakes, I guess, in the grand scheme of life, but I have them work with mantras oftentimes, like develop something they can say over and over to themselves during the test, and then learn to self-regulate through their breath so that they can calm themselves down if they get really anxious.
That's great. I think because it's so important, I think that those pieces are in the program and that early student physical therapists are exposed to that, both for their own physical and mental health. And then obviously when you start to practice, this can be really key for the different types of conditions and diagnoses that we're talking about today. I know you like to talk a lot about intensity and why intensity matters. Why is that an important topic when we discuss people with both pain and comorbid neurologic conditions?
Yeah, so there's been a lot more research in relationship to PT for people with neurologic problems and physical activity. So if we talk about people with Parkinson's disease, for example, a lot of the research now points to the benefit of moderate to high intensity physical activity. So that moderate to high intensity physical activity can actually help maybe slow down the progression of motor symptoms in people with Parkinson's disease. So it's important that they do it, right? And so if someone comes in with pain, it may be sometimes the tendency, especially of a young practitioner, to tell people to stop doing an exercise. And instead, I think it's important that even if someone has pain, we recognize that for people with neurologic problems, especially in this case, Parkinson's disease, that we need to find a way for them to still move. So even if it's the arm bike, it doesn't matter what the activity is, it's the intensity that matters. And vice versa, with people with concussion, they also need to do physical activity that's well dosed, but it's kind of the opposite. So they may need to start with something at a lower intensity, and so they can be successful, and then slowly scale up the intensity of the activity in order to improve their autonomic regulation of their heart rate when they're doing an activity. So those are two examples I can think of right off the top of my head that why I think intensity is really important. And it's really important with people with neurologic problems that we understand how not engaging in physical activity, even though someone is experiencing pain, can worsen their outcomes long-term if we tell them to just stop moving.
It's really interesting because it really speaks to using obviously a prescriptive form of exercise. And you gave really two different examples there. one with a group of Parkinson's patients where they need moderate to higher intensity, which I think most people might say was the opposite, actually, that people would need lower to moderate, because at times people with Parkinson's can be older and be perceived as more frail. But as you said, they don't necessarily have to be doing jumping jacks or running. You can achieve a high intensity exercise by using equipment or other means. Versus the traumatic brain injury population, you might have to start slower and build strength, obviously, and resilience as they move along. A little bit of a paradox there, because I really think that people see most people with a chronic health condition as they shouldn't do too much, or they shouldn't do a level of intensity. It might, affect them in some adverse way. Do we know the science behind why moderate to higher intensity helps Parkinson's versus a lower intensity? Because oftentimes Parkinson's patients wind up in a gentle yoga class or a gentle Pilates class or something like that, which tends to be a lower intensity, but you and your researcher are saying something different.
Yeah, so it's not my research. It's Margaret Shinkman did a great study on people doing treadmill walking. And then there's another study that talks about high intensity biking, which is actually commonly used in people with Parkinson's disease. And so I think the rationale is still developing in the literature, but it seems that possibly it's related to BDNF. So the production of BDNF that happens that promotes some neuroplasticity within the nervous system. But I thought you would like this because you're a nutrition guy. And so there is growing bodies of literature that talks about the gut dysbiosis that happens in people with Parkinson's disease. And so some of that is purportedly also possibly linked to pain. So things like the Mediterranean diet and stuff like that may also, educating people on that may also help with managing pain in that population and help to control inflammation. And the same can be true with people with MS. So it's really important also that there's this holistic approach to the way we're working with people. And I think the integrative lifestyle medicine really lends itself well to that overall. I went on a little bit of a side.
No, that's perfect, because really what you're saying is for us to optimize the nervous system, many of these conditions research is still building, but may start in the gut. There's some research that with Parkinson's disease, there may be pesticides that are on plants that we're eating and ingesting. And that's how it's entering, through the gut tract and up the vagus nerve and into our brain and perhaps the portal circulation, as you know. So there's an aspect of healing the gut that would come into play, but there's also this aspect of exercise where you can upregulate bone-derived neurotrophic factor, which is important for that neuroplasticity. So we want to make sure that we can grow new synapses and connections and promote neuroplasticity. So I always love tackling things from two different avenues, because people are eating all day long, right?
Yes.
There's an opportunity for us to help them there. And people should be, or hopefully are moving their bodies all day long. So there's an opportunity for us to help there.
Yes, the movement is the way we connect with the world around us. Whether we're moving in a wheelchair, on our feet, or with a walker, it's how we typically engage in relationships. And so, one of the big things I think people with neurologic diseases face is kind of an immediate, when they get the diagnosis, there's a psychospiritual injury that happens really right away, because it's like this ball is dropped on them that they have to carry, or they choose to carry, or maybe a really insightful healthcare provider can help them put down and learn to navigate life with this health condition artfully. And if movement is not a big part of their plan of care in a way that is targeted for their disease process, then it can really make it harder for the person to live a well life for a long time.
So you mentioned psychospiritual aspects. You actually mentioned it early in the episode too, and I just kind of put a little tag on it, and I just kind of let it go, and then you brought it back up again. So I want to touch on that for a moment. So definitely, when we think about people with trauma, and obviously it sounds like you've worked with potentially veterans of the military who have had obviously physical as well as psycho-emotional traumas. Why is it important for us to keep that into consideration? And how does that begin to connect with what we do as healthcare professionals? People would, say, well, movement, exercise, how does that connect to my psycho-spiritual essence, so to speak?
I had the benefit of co-teaching with the chaplain at Camp Lajune. And one of the things he used to talk about was that spirituality is really impacted by our ability to connect with the world around us in a meaningful way. So I think when I talk to my students about why people come to physical therapy, it's never to address an impairment. No one cares if they have decreased shoulder range of motion.
Oh,
they
boy.
care.
So let's just stay on that for a second, because we have a very impairment focused profession.
Yes.
Which it sounds like you and I are on the same page with that, right?
Yes.
I mean, a lot, we have changed dramatically as a profession, but we still have, even the ICF still has somewhat of an impairment focus. But what you're saying is that, yes, there are impairments there. We should ignore those, right?
Right. We should not ignore them.
Right. But people aren't necessarily coming in saying, I'm lacking 35 degrees of external rotation up at 45, and this is a real problem in my life. So if they're not coming in with that in mind, what are they coming in with in mind?
I think the people that I work with come in with worry that they're not going to be able to participate in their life, or they're falling, and they are scared they're not going to be safe to function in the community. And they want to be able to go to church, or they want to be able to play with their grandkids. It's never about their foot drop. Mm-hmm. Not necessarily. It may be about their foot drop and their tripping when they walk to the grocery store. And so we have to address the foot drop issue. So it's not that impairments aren't important, but it's not the driving factor. It's not the salience, right, that is sending someone to therapy that promotes neuroplasticity. So when we think about the principles of neuroplasticity, salience is one of them, because people pay attention better when they care about something. And so I think we can all get better outcomes in a physical therapy if we're intentionally goal setting with our patients in a way that is shaping their physical therapy, their time in physical therapy towards meaningful activity instead of just addressing an impairment.
So if I hear you right, there's a piece in there about valued life activity domains.
Yes.
So being a member of the community, being a productive member of the community, being a part of a social system with friends and family, being able to engage in employment or potentially education in school. And we as professionals, as PTs and other health professionals who all listen to this episode, this podcast, we should keep those value life domains in the back of our mind, and obviously in the room with us and in the container that we're treating in with the patient. And that's how we set our goals. There's another piece in there when you start to talk about spirituality that starts to discuss or really tap into the idea of identity and autonomy for people.
Yes.
And how important that can be in someone's recovery.
Yes, so that's important for motivation, having the ability to make choices about one's plan of care or goals. This was a big area of learning for me. So I did a study on medical therapeutic yoga for people with MS several years ago, and I let patients set their own goals. I didn't even look at them. And so that was a very novel thing for me to do. I'm going to just let go of control and let people do this. But people could set goals that were really salient and meaningful to them. And we just coached them through how to set SMART goals. And they did a great job. So I think that salience piece and letting people have the ability to choose and be really solid partners in a plan of care helps internalize motivation, and it also helps them build self-efficacy.
Mm-hmm. And I wonder how much stress it took off you as a professional that they were allowed to really develop that piece on their own.
Yeah, I mean,
because that's really a patient-centered. I love that. It's a patient-centered way to look at things, because they're really guiding their care and their recovery process.
Yes, that's true. There's this guideline or this clinical tool that we can use in stroke recovery called the goal attainment scale. And that's what therapists coach people how to set their own goals through this scale. And I've always thought it would be great if it was used in chronic pain, because it really makes sense to allow people to learn. I think one of the things that we do in neuroclinical practice, or that I try to do, is to set a big goal and then show patients how they're going to take these stepwise goals. They're going to walk up this staircase to get this bigger goal that they want to achieve. And the goal, that's what one of the things the goal attainment scale does. So anyhow, I think goal setting is one of the things that when I was planning for this, that I really felt like was an important thing to talk about.
So we've talked a little bit about physical activity, promotion of exercise. What are the barriers that sit in the way of the physical therapist from helping or promoting or counseling on effective physical activity promotion for this particular population?
So overall, I would say that physical therapists, I think, tend to have poor self-efficacy for prescribing physical activity for community dwelling adults and older adults. And that doesn't include people with neurologic problems. So I think there's a lack of awareness of how to promote exercise in this population, or physical activity, and fear about that they're going to hurt someone or that they're going to fall. And so I think we just need to do what we can and with what we're comfortable with these individuals that we're working with, and make sure in some way that within any orthopedic precautions they might have, that we're just sending them on to some kind of physical activity. I think another is just bias. And it's interesting because you kind of brought this up earlier about how the tendency would be to think a person with Parkinson's disease should do low intensity physical activity, and a person with maybe a concussion that's an athlete should do high intensity physical activity. And the goal for the person with the concussion that's an athlete, right, is to get back to high intensity physical activity. But there are all these systems impeding their progress, like the oculomotor system, the cervical, and so forth. And so we have to start them and walk them through that process. And I think recognizing, I know for me, I talked about this morning in lecture, I have to recognize my internal bias with physical activity and what is valuable to me and what is not valuable to me, and recognize that it really, in the end, it's about the patient being the best version of themselves that they can be. And it's my job to walk with them on that path. And I have to recognize my own bias and think about how I can best prescribe exercise to meet that person's needs, and what's also in line with what the literature says. And another thing that I think is a really big problem is a lack of accessible equipment. So fitness facilities overall are not, and communities are not set up well for people with neurologic problems to walk in the community. So for people with MS, for example, it's important that fitness facilities are really climate controlled because of their heat sensitivity. And for people living life in a wheelchair, the built environment really impacts their ability to access the community.
So we've kind of drilled down to some of the details. If we pulled back from it and I just asked you, if I just wanted to choose a couple of general health promoting activities that all of us should be aware of, those of us that are healthy, those of us with orthopedic problems, those of us with pain, neurologic problems, what are the general lifestyle recommendations and healthy habits and behaviors that we can begin to implement to keep our nervous system functioning in a way that is healthy for our lifestyle?
Sure. So getting healthy sleep is important. So sleep, engaging in habits that are healthy from a sleep hygiene perspective, is valuable for many different people with neurologic populations, but is also important as a preventative measure. Eating, I think, a plant-based diet is great because it helps control inflammation. That's one. And then physical activity is another one. So it's interesting because I don't think really any one of these things necessarily prevents any one disease from happening or is a fail-proof thing for every single person. But when you start putting all of these together, it really can improve someone's well-being. So those would kind of be three that I would say are really important. And then overall, avoiding injury. So avoiding head injuries and spinal cord injuries and especially for young people. I think educating younger individuals on what can happen if they're in a car accident so that they understand maybe a little bit more the ramifications of catastrophic car accidents. I think we should have those conversations instead of shying away from them. But
yeah, and I know a lot of physical therapists are more involved in the TBI space, things like helmets and other protective equipment, or even exercise programs to try to build up resilience should those things happen. Those are important components, but probably not as important as the ones that you mentioned. Early on, we spoke about mindfulness. Does mindfulness have a place in optimizing kind of the normal health of our nervous system?
Yes. So I think being able to upregulate and downregulate your nervous system equally well is really valuable. And so one of the things that I frequently tell my students is I think they're all experts at upregulation, right? They spend all this time with their sympathetic nervous system on overload. And so, but then something happens and you can't move, right? Like you have an injury and movement can't be the way you deal with it. And so being able to practice mindfulness or a meditation practice in general, and having control of your breath and being able to use that so that you can still navigate life from a place of peace is really important. And I think I'm really glad you brought this up. And people with neurologic problems, I think it's really also very important that they gain this mindfulness piece, because at some point there's probably going to be a time when maybe they have a fall that's going to keep them from being able to move in the way they want to. And being able to still have a sense of self-worth and value and navigate that time artfully is really challenging if you haven't practiced it before you have the life experience. And I know in the military environment, certainly, that maybe they're teaching these skills earlier on, but for these young men and women that have served their country, teaching them after the fact when their nervous system is in a state of disarray is much more difficult than it is if they were taught on the front end how to practice mindfulness or breath work or some kind of meditative technique to help them self-regulate.
So you're saying that we should be able to experience both ends of the spectrum of our nervous system function, both kind of the down regulation, more paused and relaxed aspect of our nervous system, and be able to access when we need to, how to upregulate our nervous system activity. And then probably at some point be able to find all the various points in between that we go through sometimes on a normal daily basis, right? Because if you're in traffic, if you're going to work in the morning and you wind up in traffic, nervous system gets upregulated, obviously not as upregulated as when you might be in a car accident, let's say. But being able to notice and be able to observe each of those states as distinct, and then having the tools to regulate your own nervous system in and out of all those states really is part of being a whole human, right?
Yes, it very much is. And I think it's part of the messiness of being human, right? And being able to embrace that. And for me, this is a very vulnerable activity for me to be on a podcast. So I have to do both, right? I have to try to manage and ground myself. So I practice breathing while I'm here, right? And then also bring some energy and vibrancy to the conversation at the same time. So there's this duality that happens, and learning to hold both of those simultaneously. Like, can you hold pain and still move forwards at the same time? Does the pain have to be crippling? I think those are some of the gifts of mindful practices. I know one of the things I tell students all the time is that I think one of the things as neuro PTs that we do is we help patients hold hope and despair simultaneously. And so oftentimes the people that we're seeing have had something terrible happen to them, and they're in the worst circumstances they could ever be in their life. Maybe they're fortunate enough to have significant family resources, but lots of times that's not the case. And we have to figure out how to help them hold hope while they're moving through this kind of situation that is just full of despair. And mindfulness is the way that I learned to do that. So for me, it's a priceless practice that I really think is invaluable for anyone, and definitely makes life easier, where whether you're dealing with a physical pain or a pain that's more psychospiritual, it just is a skill that you can't really put a price on it.
That's really wonderfully said. So as you're saying, we have to psycho-emotionally and spiritually hold the idea for our patients of hope, as well as a little bit of despair that we're working through at the same time. So that's on a kind of a more cognitive level. At the same time, be mindful of our body and the body fullness experience that we have, and be able to move in and out of regulated, dysregulated, downregulated states as part of that hope and despair experience.
Yes.
Yeah.
Yeah, it's hard.
I love that. It's hard, right? It's hard. And this is where the work comes in with us, with patients, right?
Yes, and on ourselves. I think it's hard to teach other people this if you haven't had the experience of what it's like.
Laverene, as we start to wrap up, I know you have these 3 recommendations that you oftentimes share with both people who are living with pain and comorbid medical conditions. I'm wondering if you can share those with ours and tell our community what they are.
Sure. So I think number 1 is just keep them moving. So even if it's the arm bike, lots of times it's intensity. I know for people with MS lately, I've been working a lot on step counts with them. So there's a great study by Valerie Block that talks about people with MS that walk on average more than 4,766 steps a day are less likely to experience a functional decline. So we work a lot on just stepping. They don't have to necessarily do any kind of intense physical activity. Just getting in those step counts can give them a positive prognosis. I also think then that education, this leads well into the next one. So educate people. Tell them why you're having them do things. So pain neuroscience education does a great job of this, because it really explains to people why their behavior is important and how that's driving changes in their brain. And so for people with MS or Parkinson's disease, it's not enough to tell them to do something. It's important that we explain what the neurobiology is and what the impact that the activity is having on their disease. So that helps shift motivation from being extrinsic, like a you do this, to, oh, I can have control over my disease if I do this. And that can then help the physical activity become more of an identity component. And then the third, I would say, is work with patients to set achievable long-term goals and then follow the patient. So there's a big shift in neuro-PT towards seeing people using more of a dental model. So maybe we follow people or see them for a large dose of therapy. So maybe we see them 2 times a week for 4 weeks for a little while, but then we don't necessarily discharge them. We have them come back in 6 months. And so when we see people in this way, 1, it lets us establish a strong connection with the patient, but 2, it also gives us the opportunity to follow them across the disease spectrum and know how to progress their activity and continue to set goals and modify things so that they can be the best version of themselves for as long as possible.
I appreciate that. I always thought the idea for so many of our patients, the idea of discharge is just a wrong, it's created by the insurance companies, which we all know. But I really think we should have a long-term view as a profession. Yes. And see that we can be an important part of someone's health, well-being, and should it be a disease process, that we can be there with people all the way from the time when they're young throughout the lifespan to, very, very, very late in life. And people should come back for check-ins and checkups. And so we can be engaged in that resilience and positive growth that people are looking for throughout the spectrum. Laverene, it's been great speaking with you today. I know everyone is going to share this with their friends and family on social media, on Facebook, LinkedIn, and Twitter. Instagram, you can, of course, tag me at drjoetatta.com. Where can people find you and learn more about the work that you're doing?
So I have a Twitter account. It's at LavaGPT. And also Winston-Salem State. So if you look me up at Winston-Salem State, you can find me here and get my email and send me a message. I would love to hear from people.
Great. So of course, all those links will be on the show notes at the Integrative Pain Science Institute on the page for this podcast. And again, that Twitter is at LavaGPT. That's LAVAGPT. And of course, the Winston-Salem physical therapy program is where you can find Dr. Gardner. Thanks for joining us again for the Healing Pain Podcast this week. Make sure to share this episode with your friends, especially people who have comorbid, orthopedic, neurologic, and chronic pain problems. I'm Dr. Joe Tatta. We'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativePainScienceInstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.